So at the outset, I would like to thank the organizers, Dr. Ruchi Gupta ma'am and Dr. Kalikar sir, for giving me this opportunity to share my experience related to flow cytometry. So I'll start directly with my case one, a 66-year male who presented with complaints of weakness and weight loss for 3 months and 2 episodes of epistaxis. When he visited the clinic, he did not have any palpable lymphadenopathy or spleen or liver enlargement. There were no skin lesions or other B symptoms like fever, night sweats, and there were no other bleeding symptoms. This epistaxis was the first episode he had since during his lifetime. So a routine CBC and a coagulation profile was advised, seeing the history. So seeing the smear here, it is a 20x view. You can clearly make out that we have these lymphoid cells and we have these smudge cells. So the lymphoid cells are small in size. They have condensed chromatin, and I'll just show you a higher power view. Here you can appreciate the soccer ball appearance with condensed and light and dark areas. And here you can see a cell with little bit more of cytoplasm and a prominent nucleoli, which we may attribute to be a pro-lymphocyte. So the morphology was relatively clear with smudge cells, lymphocytes predominating and occasional pro-lymphocytes. The platelet count was preserved to around 1.3 lakh in this case. So what we could tell him was a chronic lymphoproliferative disorder, but the cause of epistaxis was still not clear from this. So seeing the CLPD panel from the peripheral blood sample was run. Here you can see the initial plots, as you might be seeing since last 2 days. So here is the plot which we do gating in CLPDs by CD19 versus side scatter. So we can see that the CD19 population is increased as compared to your CD19 negative. So this is one of the abnormalities which we were expecting. And these cells are showing bright expression of 45. So the next step is in any CLPDs, you have to document that the proliferation is clonal. So here in this plot, you can see we have some normal lambda positive cells, maybe residual B lymphoid cells, and very few dots in the kappa region, but our majority of the population is showing moderate expression of kappa. So again, favoring a lymphoproliferative disorder. So the next, what we expect in CLL is expression of 5 and a heterogeneous 20. So our case followed that rule. It expresses 5. We can compare with your normal T lymphocytes, which are expressing bright 5, and your population is this B lymphoid population is trying to encroach there. And they're having, these are your normal B residual lymphocytes having a bright 20, and the malignant cells have a lower CD20 here. Then the next step is expecting is a bright expression of 200 and 23. So by now, till now, the case is looking like a case which follows all the book rules. And FMC7 was negative and 10 was negative. You can compare here with, as initially I gated in the initial plot, was your granulocytes, which normally express 10, which has come beautifully in them. But our population of concern is negative here. So the case had 64% CD19 positive lymphoid cells with bright 23, 200, moderate 5, 20 heterogeneous, kappa moderate, negative for 10, FMC7 and lambda. So should we sign out the report? Or we should look at the other markers as well. So you can see here 3 is expressed brightly by your T lymphocytes, 4 and 8, and your population here is negative, your B lymphoid cells. But this tube makes it interesting. Here you can see your T cells are expressing 7, and so are these malignant cells trying to acquire 7. So you can say they are expressing 7 in a heterogeneous pattern. So the markers positive for T lineage have come out to be 5, which we expected, but 7 is again a heterogeneity we didn't expect. So any more markers to be run here? We have to run all the B cell markers. So we did run 2 in a separate tube, repeating our test because we did have 2 in the same fluorochrome. So we repeated it with 19 APC and 2 in PSI7. And here again, we can see that your T cells are expressing by 2. And again, your population of interest is trying to encroach that expression, again giving a heterogeneous expression of 2. So now what adds to the typical book picture is a heterogeneous immunophenotype with 7 and true expression. So a peripheral blood flow in fish was performed outside, and it did not reveal any routine screening panel abnormality in fish. Other parameters like LDH, LFT, KFT, uric acid were within normal range. So it was a case of BCLL with aberrant CD2 and 7. So we started searching the literature. So what we could come across of the largest series of cases analyzed by Kampalat et al. They have analyzed 117 cases of CLL for aberrant expression of 2, 7, 10, 13, 33, and 34. In their study, they could find only 2 cases expressing 2 and 7 in combination. In these cases, the chromosomal analysis was not done. And overall, there was no prognostic significance of the aberrant expression of 2 and 7. It is controversial, but what they could interpret from the expression of all the aberrant markers was overall aberrant marker expression is associated with significantly decreased overall survival compared to patients without aberrant markers. Our case is new, just visited our lab 1 month back, so we'll have to follow him for this data. Another case which we could find in the literature was of combined aberrant expression of CD4 and 7 on BCLL. This was again a case of an elderly male, 78-year male. Again, the clinical presentation didn't have any significant abnormality, but the immunophenotype did show some unusual expressions in the form of bright CD79B, which we know usually CLLs are negative for. The case also had FMC7 and a bright kappa, and there was no abnormality detected in the fish. So the take-home message for this case is T markers in CLL, are they really relevant? They just at present depict a immunophenotypic heterogeneity in the B lymphoproliferative disorders. The prognostic significance is still uncertain. Now, how we can explain this? It could be a malignant transformation of progenitor cells with potential for multilineage differentiation, or it could be because of the deregulated expression of genes leading to activation of your T cell differentiation genes expression. So we have been lucky enough with regards of this entity of CLL expressing CD8 T cell markers. We had also witnessed a case expressing CD8 in a classical phenotype of CLL, which we had published in Clinical Cytometry. So coming to my second case, again, an elderly male, 63-year male, complaining of weakness and abdominal fullness for 4 months, and some more history for hematology, presenting with spleen, and liver enlargement, along with generalized lymphadenopathy. The patient did not have any skin lesions, fever, night sweats, or bleeding symptoms. So likely profile from the clinical history makes it likely to be a lymphoproliferative disorder. So first and foremost, we'll see the peripheral blood smear. So here you can see that there's an increased count, and you can see there are increased in the proliferation of lymphoid cells. Now, this is a normal lymphocyte. If we compare with this, we can see the cells are larger, that is medium sized, and they have irregular nuclear outlines. Few also had slight cytoplasmic projections. Few more views from the slide. Few of these showed presence of nucleoli. And here again, you can see presence of nucleoli along with the irregular nuclear contour. So the morphological diagnosis was of a chronic lymphoproliferative disorder. To give respect to the most common entity witnessed, CLL was kept as the first differential or a progression to PLL. Then the other entities were kept as marginal zone lymphoma, seeing the variable morphology. Then a proliferation of T cells, including adult T cells or TPLL, because of the presence of those convoluted nuclei with prominent nucleoli. So in addition, the patient investigations were sent for viral serology for HIV, HCV. All the viral markers were negative, including HTLV1. Then the serum calcium, liver function, renal function were unremarkable. The LDH was raised. So the next step was again to go for immunophenotyping to confirm the diagnosis. So here you can see that in this plot, your 19 positive cells gated here are relatively normal in amount, and the major chunk is CD19 negative. So our initial differentials of CLL, CLL bar, PLL, marginal zone were out on this plot. Now, here you can see that these cells of interest, these are positive for 7 and 3. Then in the 4 and 8 plot, you can see there is some population which is 4 and 8, and a major chunk is positive, dual positive for 4 and 8. And 2 and 3 are positive here. So I think you can make a diagnosis from this. TPLL. Yes, it is that only. But just because of rarity, I've just put it in so that we can remember it as an entity more clearly. Then you can see here 20 is negative and the cells are expressing 5. They're expressing 3. And your cortical markers 1A is negative, 56 is negative, and they are expressing some degree of 38 and 10 is negative. So we had this is the summary: CD19 negative cells positive for your pan T cell marker 7325, dual positive for 4 and 8 with a bright 45 expression and dim 38. And your post-thymic, it was a post-thymic phenotype because 1A and TDT were negative, and the other markers 25, 10, 25 for adult T cell leukemia lymphoma was negative, 10 for angiomyoblastic was negative, 56 for NK cell was also negative. So coming to the consensus, the diagnostic criteria for T prolymphocytic leukemia, this is the enlisted major and minor criteria, which you require either all 3 major or 2 major, and at least 1 minor is required for the diagnosis. So now coming to a brief description of this entity is, we know that prolymphocytic leukemias are known for variable morphology. Typically, 75% cases will have this classical morphological expression with medium-sized cells with prominent nucleoli, regular nuclear outline, and a basophilic cytoplasm, few showing the cytoplasmic projections. But this morphology is seen only in 75% of cases. The others will have variable-sized lymphoid cells, as in our case. Some might also have larger lymphoid cells with inconspicuous nucleoli, and some may have just your irregular nuclei representing the cerebriform appearance. So flow cytometry will be the one which will help you delineate the differentials. So this is again from a paper from the Japanese group. They had analyzed 13 cases, and they have shown that typical PLL morphology was seen in 7, rest 20% at the small cell variant and 5% at the cerebriform variant. Now, since we are dealing with the flow cytometric approach, a bit about the immunophenotypic characterization of T cell PLL. From a series of 20 cases, we can see that majority have a homogeneous clone, but few may have 2 or more distinct populations, as you might have witnessed yesterday in Dr. Jasmita's talk. There can be biclonal populations in CLPDs also. Usually CD5 is strong positive, but you can have cases which lose CD45. CD3 may be weak, or it may also be lost in a small proportion of cases. So if you see that most express pan T cell antigens at normal intensity, and there can be aberrancies in decreasing frequency of 7, 5, 2, and 3. So here are some interesting case reports from TPLL, reporting a case of TPLL negative for surface CD3 and CD45. This is from publication in Blood in 2018 from a 75-year male presenting with mild leukocytosis and a large CD45 negative population. But they could show the diagnostic TCL1 positivity in these cases. And this case was also negative for surface CD3 along with CD45. So we know that there can be a lack of expression of surface CD3, lack of expression of CD45, but a simultaneous loss of both is rare. Then this is again another case showing an aberrant immunophenotype in a case of TPLL with no expression of surface T cell receptors or surface CD3. This is from a follow-up case of renal cell carcinoma, 80-year female. So from all these case reports, we can just imbibe that there can be negative CD3 reported in around 6 to 19% of cases, although the classical phenotype says it is positive for pan T cell markers. Then you can have negative T cell receptors reported in around 4 to 18% of cases. Both being negative CD3 and TCR receptor are relatively rare. So my cases are quick. They are simpler. So I'll come to my last case. So this one is a case which I've put in because it is a diagnostic dilemma. Still, we are dealing with it. So I like to have inputs from the faculty members here or from the audience. So this is from a 4-year male child, symptomatic for 6 months with a complaint of off and on fever. decreased appetite and weakness. And when he presented to our lab, he had these flat reddish macular lesions with a indurated base and a reddish outline. And these had started from his lower limb, progressed to upper limb and face. In addition, the patient had a palpable spleen, liver, and his ultrasound reported mesenteric lymphadenopathy, but the peripheral lymph nodes were not enlarged. So when we saw the peripheral blood smear, we could see that majority of the cells were lymphoid, and they were small to medium sized, and the chromatin relatively was condensed. Few had a little bit of open chromatin, but majority had condensed chromatin. I'll show you more views. This is the higher power views, and we could appreciate this cleaving in these cells. Several showed this irregular nuclear outline. So since the presentation was like a lymphoproliferative disorder, the clinicians have suspected acute leukemia. A bone marrow was also done. Here you can see the particle relatively shows a normocellular marrow, and you can see a megakaryocyte here, which were preserved. Even the platelet count was preserved in the peripheral smear. Now here you can see that there was presence of your granulocytic precursors in fair numbers, and there were erythroid precursors also. But interspersed in between were these cells of interest, as you can see here. Again, showing a small to medium-sized morphology with condensed chromatin, no conspicuous nuclei, but with irregular nuclear outline. So this case was reported as bone marrow showing increased proportion of lymphoid cells, advised evaluation for viral serology and immunophenotyping to conclude the diagnosis. So the initial flow cytometry was not performed at our institute. It was outsourced at some place. Okay, I have some more slides, some more pictures if you are interested. For these cells, again, showing the condensed chromatin and irregular nuclear outline. Few were a bit larger sized, showing little blastic morphology. So I was here. The outside flow cytometry reported as TALL, and the patient was started on the ALL protocol with vincristine, daunorubicin, and other drugs. And the multiplex RT-PCR done for the ALL was negative, but the patient did not respond to the chemotherapy. So they followed the patient for day 8 blast. There was no remission. And at the day 29, again, the counts were in lakhs and there was no remission. So the clinicians requested us to repeat the flow at our site, and a viral serology was sent this time. So these are the flow plots. And you can see here, this is the population. It is brighter for 45, but there is some heterogeneity we can see. Then these are the plots from the B tube. We can see that this is your 20 population, and this is a major chunk which is negative. 10 is negative. There is some expression of 38, but 34 is negative. Then here again, you can see 25 is negative. And I think I have wrongly put this plot here. It would have been TDT, I think, but I have missed that. TDT was also negative. And here again, 34 is negative. Now coming to the T cell tube, what we can see is there are some cells which are positive for 4, and these cells are showing some degree of 8 expression. Then if you see that majority of your cells are negative for 5, this is some residual normal populations showing 5. Then they are positive for 2, and you can see they are nicely expressing 7 and 3. And there's some degree of 56 expression, however, 16 appears to be dim. So the immunophenotype given was CD45 bright lymphoid cells with bright 7, 3, 2, moderate 8, dim 56, and it was negative for 5, 4, 16, 34, TDT 19, 9. So what category does this patient fit into with the immunophenotype? T cell lymphoma. And we are now doing the T cell receptor gamma delta and alpha beta in a lab. So we could see that there was the major population had TCR gamma delta expression. So, but the case doesn't end here because the lab doesn't stay away from the clinical profile of the patient. So the follow-up says is that once we said that it is not a ALL, even in the morphology, we hadn't committed it to be ALL. Our flow didn't show presence of blast, 34, TDT, 99, all were negative. and there was not much of aberrancies that we could conclude it to be a TALL. The clinicians stopped all chemotherapy for this patient. So the patient visited us in October. In November, the flow was repeated, and since then, all chemotherapy was withdrawn because there was no documentation of it being a TALL. And the virology showed positivity for EBM IgM. And since November, the patient has just been kept on follow-up with systemic antibiotics and all. And the last TLC around 2 weeks back had a count of 30,000, and the spleen and liver are not palpable now. So what do you say? Is it a lymphoproliferative disorder with malignant lymphoproliferative disorder, or is it a reaction to the EBV infection, which has been mimicking a presentation of a leukemic presentation? So here in this last plot, this is your normal population, this is 7 and 3. They are expressing some degree of 8, 5 is lost, and some 56 expression we can just little, मतलब थोड़ा सा है, 56 थोड़ा सा आ रहा है, और gamma delta आ रहा है, और patient is now off chemotherapy and he is we'll be following up the case. सर 4 साल का बच्चा है. हाँ मतलब there are just case reports, मतलब उसमें लिखा है कि it can be in any age. No sir, only these symptoms he had skin lesions, वो भी subside कर गए. Oh, ma'am, actually, when the patient presented, they didn't suspect. It was like the flow was performed and it was TLL and it was started. And now there are no skin lesions. The skin lesions have subsided. So what is, we can follow the case clinically, because as what we read in literature, hepatosplenitic is an aggressive lymphoma. Will it go away or it will come back? Yes, we cannot rule it. So yes, Dr. Jasmita is also there. I did misuse. Please, your inputs as well. Is in favor of that, yes. 4-year-old male. हाँ, we would have been. Yes. हाँ, उसने steroid ले लिया होगा बाहर से. But sir, in our case, the patient received in hospital prednisolone, but he did not respond. Matlab, that is what is, even the NGS for this patient was sent, and saying that there is a T lymphoproliferative disorder. So they analyzed the NGS for those mutations, but they couldn't find any pathogenic mutation. But everything is just, we'll follow the case and let's, 30,000, it is 2 weeks back. Actually, the patient didn't visited us, so he just sent us the CBC report. In that, the count was 50 neutrophils, 40 lymphocytes. So, but we haven't seen the smear, so we just did not quote that. The TLC I've quoted, that's why. So the patient will be subsequently visiting. We'll be following him. But हाँ उस तरह के होते. Thank you. And the last, I'll just acknowledge my teacher, late Professor Ashutosh Kumar sir, my colleagues, Dr. Rashmi, Dr. Geeta, Dr. Sanjay, and my laboratory staff from our bone marrow lab and the flow cytometry lab, Mr. Sudhakar, Mr. Anand, and Mr. Hiren. Thank you.